So a very good morning to all. My discussion for the day would be that how middle income nations can help support iBanking activities in low income nations. The burden of the disease is pretty high, and it is the fourth leading cause of global blindness. Corneal blindness is quite frequent in the developing nations where most of the cornea blind live, and it also has a important socio-economic impact. And this is because it affects the younger population, and therefore it affects their visual health. This map shows that where most of the cornea blind people live, and the size of the countries are proportionately bloated to where most people have corneal related blindness. And the color coding suggests that what is the country readiness, meaning that those countries which are purple, like in India, most of the cornea blindness exists here, and the state of readiness to combat that blindness also exists, as compared to Africa, where cornea blindness is high but the preparedness to handle cornea blindness is low, and green is a medium to low level. So then most of Southeast Asia also, while the cornea blindness is fairly prevalent, the infrastructure to deal with that cornea blindness does not exist, or rather it is ill prepared to meet the burden. And therefore it is important to discuss the corneal blindness in this context. And this is a two-pronged strategy. Number one is to improve the harvesting of the corneas and also develop the eye banking infrastructure. If we purely look at the numbers, then what we see is that there is a wide variability amongst nations. So nations such as Brazil and India have very high numbers, but then there are also equally prevalent geographical areas where not a large number of transplants are being done over here. Whereas if we look at, say, countries like Ethiopia and Indonesia, even the national statistics are quite low. So in this context, in this background, it's important to understand the Indian model and the way it has grown in the last couple of decades. And these figures show that there is a doubling of the corneal collection and a tripling of the utilization, and a improvement in the utilization rate. So the challenges always remain: creating the awareness, creating an infrastructure, creating a collaboration with various organizations across the country, developing a robust HCRP, shifting to those areas where we can harvest good quality corneas which can ultimately be utilized. And that is met in addition with handling about the developing the training infrastructure, attracting talent to this field, procuring the equipment and training the surgeons to effectively use the tissues as well. So some of the experiences that we have had at LV Prasad, one of them was the Myanmar model, where we came forth with a collaborative approach to help develop tissue collections in Myanmar. We partnered with the University of Sydney from Dr. Gerard Sutton's group, LV Prasad, and Professor E. Oh, she is the professor at Myanmar Eye Ear Hospital. So one was to engage the local authorities and then also install some equipment, and this was the biological safety cabinet that was installed there. We also had people from Myanmar who were trained at LV Prasad, and we continuously engage with them on an online eco-related classroom. The eco is a nationwide classroom where we help to learn from each other's experiences. And I'm quite happy to say that under our joint consensus, we are slowly trying to have a national level eco in eye banking in India as well. Probably in a couple of months we are going to launch this too. So all this ultimately led to improvement in tissue harvesting and utilization. The blue graph shows the number of corneas that were harvested in the last decade. From 2007 to 11, there was a progressive decline. But this is not really a failure of eye banking, because Myanmar has traditionally been going through several social upheavals, and lot of political change was also happening, and even now it is behind the Iron Curtain. But until that happened, from 2011 to 16, there were a very progressive strides with rapid increase of the number of corneas that were harvested by the eye banks of Mandalay and from Rangoon, from Yangon. So the future directions will be to focus on those areas adjacent to India, where even if we are not in a position because of administrative regulations to send the tissues pro bono, but at least to help develop, create awareness systems, train people, and put them on their, like they make them self-reliant, that at least they can combat their nation's corneal blindness. And I will take this opportunity about the work that was done by the LV Prasad team over the period of years, where there was a consistent push for developing the iBanking infrastructure, iBanking training model, and a successful collaboration with NGOs and a wide distribution of the trainees in the national and international field, and also in West Africa, where we are slowly making steps to help develop iBanking services. So this mentoring, this continuous engagement, continuing to talk with each other is probably the way forward in developing a resource center, and ultimately helping mentor people who are around us but who may not have that infrastructure to develop and meet their corneal blindness. Thank you very much for your patience here.
Any comments?
Yeah, so what does the LV Prasad team, for example, if you go to Africa or something, so what exactly do you keep personnel there who come and stay there for 3 months or 6 months or something, or you come and go? Or
so we have not started the Africa model yet, but there is a possibility of. But what we did with the Myanmar model was that we first engaged with the cornea surgeons there, created a political consensus, a goodwill with the religious community leaders, and that helped create awareness about this activity. But this was done by people who are in the lead of the community, amongst their community, not by us. And regarding the training, we asked them to identify people who will be willing to pursue this say as a cornea recovery specialist. And then we had them over at LV Prasad and trained them, and then send them back. And then in addition, apart from that, there are several documentation procedures that they need to follow, the checklists, the consents and all. We helped them create those and audited their consistency in which they were following these practices.
Okay, yeah. Thanks. Because we did a similar project with our iBank with Dhaka in Bangladesh, and we failed miserably. I mean, we went twice there. What you said is that we tried to get them interested in the documentation and other things. In Bangladesh, they have their biggest blood donors. The voluntary organization which works is a group of interns. So what happens that just like Rotary or Lions, they have a social organization amongst the interns. So almost every intern who finishes his MBBS, in that 1 year, he's recruited in that, and they help to organize blood donations everywhere. So we try to use the same group to promote eye donations as well. So those interns were promoting eye donation, and we train them in collection. So again, interns being MBBS level, it was easier to train them in surgery, in collection of corneas. But where we failed was in enthusing the eye banks themselves.
Right.
So the amount of apathy and the amount, so when we donated equipment, we donated the clean air systems and HEPA filters and all sorts of things. It just went into disuse atrophy because there was no connect between the interns. So then the interns stopped promoting eye donation, because if they got the eyeballs, and the eye bank was very lethargic. That's why I asked you it has to be a team.
Yes. And also, inevitably, when we go to different communities or in different nations, the felt need might be different. For example, in some countries, while they are dealing with corneal blindness, probably infantile malnutrition or vaccination could be priority. More burning topics for them. Maternal health, child health could be more important than, say, ocular health. That could be one possibility. There are also cultural taboos in many places. Many superstitions are also there. So it is a culmination of multiple factors that ensure a success, and of course a political will is definitely required. So all these factors definitely contribute, but what we can at least have a consensus is that while we strengthen internal systems, probably collaborating in the region might also help elevate the status of the robustness of our systems, or rather externally validate them as well.
Yeah.
Yeah, training definitely we can help, but the law
Yes.
is difficult.
Yes.
Yeah,
Yes.
yeah.
And there should be a willingness from the other person to
Yeah,
learn, while
yeah.
we might be willing to teach. So that also is important in that
Yeah,
context.
what we learned from our Bangladesh experience is that we need to do better homework before we jumped in one, because we got a call from the Rotary there saying we want help. So we found the easiest was checkbook diplomacy. We spent money
Yes.
and gave them equipment and all that. But I think our homework was lacking as to what will happen, and we just wasted resources. Yeah.
Yeah.
Thanks.
This is a very interesting experience that you
Yeah.
shared.
Mm.